Welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Dr. Robert Longstaffe from Winnipeg, Canada. Dr. Longstaffe is an orthopedic surgeon specializing in sports medicine, arthroscopy, with a special interest in complex knee reconstruction, osteotomies, and knee arthroplasty. After his medical school at the University of Manitoba, he completed his orthopedic residency at the same university in Manitoba, Winnipeg, Canada. He further pursued fellowships at the Stedman Hopkins Clinic of the Carolina Sports Medicine and Shoulder Reconstruction Fellowship, yet another fellowship at the University of Western Ontario Follow Kennedy Orthopedic Sports Medicine, and a third fellowship at the Concordia Hip and Knee Institute in Adult Hip and Knee Reconstruction. He's currently assistant professor and consultant at the Pan Am Clinic in Winnipeg, Canada. Dr. Longstaffe has published widely in several international journals and has many high-impact publications to his credit. So today is my great honor to introduce you to Dr. Robert Longstaffe from Winnipeg, Canada. Over to you, Robert.
Well, thank you for the introduction, and thank you for the invitation. It's truly an honor to talk at this international meeting. So for today, I thought we would talk a little bit about osteotomies, but sort of a different perspective, just in the sense from talking about how we've learned from our past and how that sort of brought us to the present, and sort of my sort of indications for osteotomies at this time. And so when we just give a little bit of a background as to where I come from, as has been mentioned, I trained and currently work at Pan Am Clinic, which is in sort of the smack dab center in Canada. I've also had the honor to train at Fowler Kennedy in Western Ontario, which is one of the meccas in North America and probably the world in terms of osteotomies, as well as at the Stedman Hopkins Clinic in South Carolina. And it's from this these sort of ventures I've had the ability to learn from not only the giants in the field, but also I've had a number of mentors that have been influential in my sort of learnings and teachings as it comes to osteotomies, that included guys like Al Getgood and Bob Litchfield, but also sort of giants in the field in terms of Pete Fowler, who's recently passed away, but was the first Canadian president of Isicos, as well as Rich Hawkins, who's a pioneer and shoulder surgeon. From that, I've learned a lot from them. And then I've also had the opportunity, I did steal this slide from another giant, Pete McDonald from Loy, who was instrumental in bringing me to this talk, who was one of our fellows. And hopefully I was able to impart some of the wisdom that I learned onto him. And so, when we back up just a little bit in terms of the history of osteotomies, one of the first sort of reported papers was by John Ray Barton back in 1835, when he did a supracondylar wedge osteotomies for an ankylosing knees. He reported success in 12 of his 14 patients, but what I really liked when he reported on is that the two remaining that had an unsuccessful recovery perished of hectic irritation and exhaustion. And so certainly nothing that I've ever used in my OR reports, but maybe something I should include. What I also found was interesting. So though the operation was severe, was not long in duration, being accomplished in the space of about 7 minutes. And so certainly when you look at the initial history, it's changed dramatically since then. We fast forward to the 60s, and with Mark Coventry, sort of one of the first that sort of introduced the sort of modern day osteotomy using a lateral closing wedge osteotomy that was secured with staples. Did this in 30 patients, for which 18 achieved good pain and stable full range of motion. They did report some staple loosening, and then the patients were casted upwards of 6 weeks, for which they had a few that reported perineal palsies. If we fast forward even a little bit more, when we look at to Fowler Kennedy, for where I trained, they looked at their outcomes for lateral closing wedge osteotomies in 85 patients. Looking at their Kaplan-Meier survival curve over 5 years, about 73% survival, but it sort of dropped dramatically to 10 years and then even further. And what you found is that they really only had pituitaries and large osteotomes and a staple to do the surgeries. And so certainly when we look at some of the modern techniques, it's dramatically changed since then. What they found was that if you were under the age of 50 and you had good range of motion, they actually had a much better survivability at 5 and 10 years. But sort of most importantly, if they had a presence of a varus thrust, that's significantly correlated with failure of the H2 with both uni and multivariate analysis. And so certainly with the difficulties of lateral closing wedge osteotomies, you need the potential for a fibular osteotomy or having to disrupt the proximal tib fib joint Disruption in the anterior muscular compartment can potentially lead to compartment syndrome. The proximity of the peroneal nerve, the loss of tibial bone stock, which can in turn result in potential decrease or increased difficulties with subsequent total knee replacement, were all sort of things that were fraught with lateral closing wedge osteotomies. And with that in mind, that sort of brought forward the use of the modern medial opening wedge osteotomy, which is sort of introduced in the early 90s with the Poudou plates. The advantage of these was that you're able to avoid a fibular osteotomy and disruption of the proximal tib-fib joint. You had a much better ability to dial in the degree of correction. You could preserve the tibial bone stock, avoid any disruption of the extensor musculature, and sort of obviously a more advantageous incision for subsequent total knee replacements. Disadvantage with the initial constructs and the initial fixations was that you often needed requirement of bone graft to prevent non-union or collapse. And certainly if you were to think about larger corrections, they may have had to require external fixation. The results of this was also looked at Fowler Kennedy, and what I really liked about this study is they looked at their early results as they transitioned to a medial opening wedge osteotomy, and they looked at sort of dividing into two groups. Group one being as they first introduced this new technique, and then group two as they started to learn from it. And obviously, they found a much higher complication rate within the group one. Specifically, when they found and they looked at it, within group one, they had a 19% rate of intra-articular fractures. And what's good is they started to learn and analyze as to why these were happening. And they felt that they had too vertical of an osteotomy, which you can see from the picture below. And they did use initial thicker osteotomes. And from there, they adjusted to use more horizontal osteotomy planes or trajectories and thinner osteotomes. And they found that they had no further intra-articular fractures. I think the biggest thing with the use of Poudou plates, there's sort of two big issues with respect to this. One of them being that it's essentially 4 screws, right? And when you have 4 screws, there's a concern that if you get a lateral hinge fracture, this can create either a loss of correction, or you can have a result of a collapse of the plate itself. With that in mind, that can often result in individuals or surgeons being a little afraid to carry the osteotomy to the lateral cortex, or at least the center from that, which in turn, as you can see on the far right picture, results in distraction too soon, which can create intra-articular fractures. If you look at Bruce Miller's work, the biggest complication they noticed with the use of Poudou plates with their high tibial osteotomies was the loss of correction. And so with that in mind, this sort of brought forward the need for better fixation and specific locking compression plates were developed so that were born out of AO principles from trauma osteosynthesis surgery. And so what are the advantages of these? These are obviously a stronger construct. They have a very strong in axial loads. It allows for earlier weight bearing, which we'll talk about, as well as you can do larger corrections and larger BMI. And so there's a number of different locking plate technologies out there. Probably the most common, the most studied is the use of the Tomoflex, which is one that I commonly use. And we'll talk a little bit about this. So we know that influence of alignment is significant. We know that if you have malaligned knees or if you have genu varum, the chances of it increasing your risk for osteoarthritis there's abundance of literature on this. But realistically, how do you quantify malalignment and its effects on OA? And importantly, if we're going to change somebody's alignment, how do you quantify how much that you're changing or how much you're changing those loads? Really, this comes down to something called the peak adduction moment. And so this has been shown through multiple studies that it's both valid and reliable proxy for the dynamic load on the medial compartment. And it's been shown that it has a risk for disease progression. And so essentially, when you're looking at this, there's ground reaction forces, which are a result of both the angulation as well as the lever arm. And when we're doing osteotomies, we're often trying to decrease that lever arm to hopefully decrease the ground reaction forces. There's been multiple studies that look at peak adduction moments that have been looking at on both a macroscopic and a microscopic level as to the changes that it causes on not only the cartilage, but also the risk for progression of OA. And there's been multiple studies that looked at this as even 1% increase in adduction moments can have a significant increase in the progression of OA over time. Further to this, there's been multiple studies in terms of biomechanics that have largely been done through places like Fowler Kennedy, through gait analysis that looked at there's essentially 2 peak quad phases during stance that include both a quads contraction and a push-off phase. And from this, they've been able to note that there's knees that have OA have significant association with greater peak adduction moments and greater frontal plane lever arms. And you can look no further than a study that was performed again out of Fowler Kennedy, looking at 126 patients that had a HTO with a poodoo plate, for which they found that their peak adduction moments were decreased upwards of 50% at 2 years. In terms of also having patient-reported outcomes in terms of KOOS scores, mechanical alignment, all improve at that point. But importantly, these peak adduction moments were able to be maintained at a less level of 50% upwards of 5 years afterwards. So essentially, as I mentioned before, what we're trying to do is we're trying to decrease that lever arm by straightening the knee to hopefully decrease the ground reaction forces to lessen the load on the knee. And so when we look at osteoarthritis or we look at any type of arthritis, there's multiple factors that play a role in the development that include both the predisposition in terms of age, genetics, systemic factors, as well as biomechanics. And largely what we're doing from an osteotomy standpoint, we're trying to change the biomechanics that hopefully will lead to a lesser environment and a biochemical pathways and the development of osteoarthritis or progression of pain. Common questions that I get with respect to osteotomies, obviously, is, will this compromise a future TKA? Will an HTO end my athletic activities? Will this solve my arthritis problem? Probably the most common one that I get is, how long will my osteotomy last? And so, when we look at survival analysis, this is a systematic review. It's a little bit older, performed in 2013. When they looked at their survival analysis, they found at 5 years, osteotomies were approximately 90%. This decreased to about 71% at 15 years. But importantly, if you look at this, you look at the studies, this is a wide spectrum of age, and this is also a wide spectrum that included both lateral closing, medial opening, poodoo plates, staples. So a wide spectrum of specific fixation, and a wide spectrum of heterogeneity, where it's hard to sort of tease out if we're using modern techniques as to how long osteotomies would last. Another systematic review looked at, what about comparing open versus closed HTOs? At 5 years, there's no real significant difference, but when you start to get further out, and at 10 years, they started to notice a bit of a difference that was statistically significant in terms of having an increase to survival with open versus closed. From this, they were able to conclude that there is obviously, as we sort of mentioned before, more accurate correction with open HTOs, as you're allowed to address both the coronal and sagittal plane. And there was more difficulty in addressing the soft tissue laxity, i.e. the double or triple varus or adduction moments with lateral closing. But what about, with modern osteotomy techniques and plating, what are some of the, how long do these last? And so certainly when we look at a few studies that are starting to analyze locking plate technology with the use of osteotomies, I think we're going to see that it's even improved survival from this. This is a study back in 2015 looking at tomofix fixation, and they found it up almost close to 10 years, 95% survival. The important thing to stress is if you look at that graph, the green bars represent what their level of osteoarthritis was pre-op versus at their final follow-up. And I'll pose to you that none of them had a grade 4 changes at their initial surgical date. And that's certainly something that you want to target. If you can get them at a time in which they're not bone on bone, you potentially have a chance to have them survive even longer. Another study looked at 10-year survivability in which they had early weight bearing without filling of any of the defect, and they had an 88% survivability at that point. And so when we look at templating, typically the classic sort of templating is Fujisawa's point, or the down slope of the lateral tibial spine. When we template, that often gives you an angle, but specifically, how do you get how much you want to open? And specifically, if you're doing a medial opening wedge osteotomy, how much of a correction do you need to perform? And so this is an example from my templating actually recently, as of 2 weeks ago, Typically, the way I do it is obviously you need standing full-length weight-bearing films with a templating ball. I will mark out my osteotomy trajectory, my line, which is signified by line A here. This allows me to get my length of my osteotomy and also allows me to get my trajectory. From line A, I will then mark out, as we can see, we marked out our angulation here, which shows an approximately 11.7 millimeter correction. We want to create a hinge with respect to this, as we don't want to have a lateral hinge fracture. And so how we template the actual correction is that we take approximately a centimeter off of my osteotomy trajectory, which is 66 millimeters. We move upwards 55 millimeters from line B. From there, I will measure the distance between the angulation, which comes out to 10 millimeters, and thus I will plan for a 10 millimeter opening wedge osteotomy. This is a technique that, a video, I'll just stop for a second, that was performed at Fowler Kennedy with one of my mentors, Bob Litchfield, for which I performed the surgery with him. And so I want to give acknowledgments to Fowler Kennedy and to Bob Litchfield. It's a quick video just showing essentially how I still perform my osteotomies. The incision is probably a little bigger for the video than what I normally do. The initial step is to release the pes and to release part of the hamstring tendons to allow for visualization of the posterior border of the MCL. Once the MCL is identified, this allows for a Cobb retractor or Cobb elevator to essentially bluntly elevate off the back of the calf musculature. I will often stick my finger in back just so I can feel the fibular head to ensure that all the soft tissue muscle is off. Once that is off, then it allows me to place a blunt Holman. And then from there, at approximately the sort of metaphyseal diaphyseal junction, I will follow my initial guide pin, for which we're sort of aiming to the proximal fibular head. This is a little low trajectory, which was adjusted afterwards. You typically want to aim, and I'll have pictures afterwards, towards the tip of the fibular head. Once we have our trajectory identified, there's a number of ways you can address the MCL. Some will sort of peel as a large L. Some will do a transverse cut, which was done here. And some will just elevate it off while keeping it attached distally and proximally. But importantly, you do have to elevate the MCL. A thin oscillating saw will use largely just to cut the posterior cortex, or sorry, the cortex itself. What you'll notice is this is a biplanar cut, and we'll show videos with respect to this as well. The patellar tendon is identified and it's retracted to allow for the biplanar cut. We use chisels, and so instead of using initial osteotome, I will use a thin chisel. Again, this goes back to the old literature finding that thicker osteotomes could potentially result in propagation of fractures. And so this is a thin chisel that I initially use to progress my osteotomy. And then once I'm comfortable that I've had my osteotomy towards the lateral cortex, then we will move up to an osteotome, which is thicker. The whole idea of this is to try to have a slow creep to the bone to try to prevent a lateral hinge fracture. Periodic fluoroscopic images would also be taken just to confirm our trajectory and that we're happy with respect to this. And probably the biggest element is that I don't distract until I'm able to see this. Once we're able to see movement of the proximal tibia, then I know that it's able to be distracted. And likely the most reason is that the posterior cortex has been cut enough to allow us to do this. This is a laminar spreader, which is used, and importantly, this is used on the back of the posterior cortex because we want to create a trapezoidal shape. The importance of the trapezoidal shape is that you want to try to prevent any iatrogenic increase in the posterior tibial slope unless you're addressing a PCL deficient knee. The video stops here. Essentially from here, what I will do is I will pin the plate And once I'm happy with the position, I will fix it proximally, then followed by a cortical screw distally to compress the plate, and then further locking screws distally. And so this was what I was talking about before in terms of a biplanar cut. A biplanar cut allows for a more distal cut, less chance of a hopefully intra-articular fracture, allows for a larger surface area and more room for the plate proximity and less gap obviously to fill. And so when we look with respect to trying to avoid increasing the posterior tibial slope, the whole point of this is to create a trapezoidal shape. And so we're distracting. And when I do my measurements, I want it 10 millimeters, if my template was 10 millimeters, along the posterior cortex. And ideally, you want probably about half of that at the anterior cortex of 5 millimeters. And that hopefully will help prevent any iatrogenic increase in the posterior tibial slope. So these are pictures from a case I did a couple of weeks ago, for which, again, a guide pin is placed across. I'll use a distractor to place through after I've used my chisel and my osteotome, and then a laminar spreader. The laminar spreader will stay along the posterior cortex until I put my plate fixation in. And then after that's been completed, I will then fill this with a cancellous bone graft if the correction is large enough. When we look at early rehabilitation, historically, individuals with poodoo plates were treated non-weight bearing for upwards of 6 weeks, which is still for some done. One of the biggest advantages for me for locking plates is that I can get the individuals moving sooner and weight bearing sooner. And typically at 2 weeks, I start to get them progressing weight bearing with both the crutches and braces. And there's been multiple studies that looked at this. Is a study that actually implanted tantalum beads to see if there's any movement in the osteotomy. At approximately 2 weeks, they said, okay, you can start weight bearing, and individuals would start weight bearing anywhere from 15 to 39 days. And they found that there's no difference in the motion of the osteotomy when assessed by the tantalum bleeds. And they found achieved improvement in both pain and function with earlier weight bearing. Further studies have shown this with RCT, for which individuals were started weight bearing at 11 days opposed to 6 weeks. Again, they found increased improvements in both all patient reported outcomes compared to the delayed weight bearing. Systematic review, looking at this again, early, less than 2 weeks versus late, more than 6 weeks weight bearing, found improvements in outcomes as well as comparable radiographic outcomes from early versus delayed or weight bearing. And so this is 2 patients of mine for which the gentleman on the left is at 6 weeks and the patient on the right is 2 months. Typically, I will get them at 2 weeks to start weight bearing with brace and the crutches, and they will keep that for the first 6 weeks. After that, they can kind of discontinue it. And this is usually my hope. It's not always the case that they come in this well, but that's sort of the target goal that I want at 6 weeks, is that they're walking relatively normal with their brace and crutches. And to me, if I can get an individual to start weight bearing and mobilizing sooner, it's a much better advantageous. And it's a much easier recovery for the patient if they can start weight bearing sooner. What about the valgus knee? So certainly we talk a lot about varus knees, but certainly there are individuals that have valgus knees, and it's sort of the same principles, albeit I'll often go to the femur more often than the tibia. But again, you have multiple options that include either a lateral opening wedge osteotomy versus a medial closing wedge DFO or lateral opening wedge DFO. And there's sort of pros and cons to all of them. Typically, my decision making when I'm looking at these, I want to see, is the correction large or not? And so if it's over 11 degrees, I'll often go automatically to a DFO. The concerns with a proximal tibia osteotomy is that it, with larger corrections, can create a significant joint obliquity. And then obviously for individuals that have valgus knees, I will often do measurements, including the distal femoral angles, to determine where the actual deformity is. Is it on the femur or is it on the tibia? Advantages of a lateral opening wedge osteotomy: it unloads in both extension and flexion, sort of similar to tibial plateau fractures. And so if surgeons have experience with tibial plateau fractures, this may be a more comfortable approach for them. Typically does not require fibrillar osteotomy, but again, one of the disadvantages, it does not cannot do in larger corrections. Advantages of medial closing distal femoral osteotomy, and this is typically my go-to. It allows for direct bone contact, which creates inherent stability. No bone graft required. There's certainly less hardware irritation. It does only unload the joint and extension. It is a not as familiar of an approach, and certainly they have concerns with vascular injury, opposed to lateral distal opening wedge osteotomy, which is certainly a more familiar approach for individuals dealing with distal femoral fractures. You can access the lateral compartment for any concomitant procedures if you need to do, but some of the downsides is there can be hardware irritation from the IT band. So again, it's a biplanar cut. And so what I mean by that is there is a trajectory that's much steeper. And so typically we're aiming towards the tip of the medial condyle with our osteotomy. This shows an example of the biplanar cut. The whole point of the biplanar cut is hopefully that you create a hinge and not a complete fracture, but allows you to control both flexion and extension with that anterior flange of the bone. This shows a video of the closing of the distal femur. Often I do the same templating, but just on the opposite side with respect to this. Typically, the way it will work is that once I'm happy that I have enough ability to close a tomofix plate, again, they have tomofix plates for the distal femur, both medial and lateral as well, which will be provisionally placed on the distal fragment. This will then be fixed with locking screws, and then I will often use a cortical screw to compress the plate down as well as to close the gap, followed by locking screws. So certainly with complex knees, there's multiple issues that you have to address that include both biomechanical and well as biologic factors. But again, when you're dealing with any of these, whether or not they be chronic ligament deficiencies or possible cartilage restoration procedures, the one thing you have to look at is alignment, and specifically you got to address with any sort of realignment osteotomy. And so certainly if you have an individual like this who came into my clinic approximately 6 months ago, any sort of soft tissue reconstruction that you do on its own will not suffice. And this is an individual that needs to have an osteotomy to correct her alignment at the same time. This is something that can be addressed for individuals that have essentially four main roles: chronic anterior laxity with varus OA, chronic laxity in the setting of a lateral ligament deficiency, or chronic anterior laxity with increased tibial slope, or chronic posterior lateral corner, or PCL. So when you assess these patients, these can be complex issues. And so you certainly want to look at it. Is their primary complaint pain, or is it stability, or is it both? You need to look at patient factors that include age, their activity level, their functional demands, and obviously their comorbidities. And then certainly surgical factors, these all play a role. What kind of pathology do they have? Do they have a meniscus deficiency? Do they have articular cartilage injuries? Where is the site of pathology? And certainly what is their alignment? So this includes assessment of both the degree and the magnitude of correction, and certainly where is the deformity, especially if they have a valgus knee. And then you have to plan as to how you correct it and by how much. The most important thing when we're looking at individuals that have ligament instability or individuals that have cartilage, or you're thinking of doing cartilage procedures, as opposed to individuals with arthritis, we will often correct just to neutral. So in ligament reconstruction cases that are complex chronic, we aim for 50%, so straight neutral, as opposed to on the downslope of the tibial spine. And certainly, if you look at the literature now, there's abundance of literature that's starting to come out as to the posterior tibial slope and its effect not on anterior cruciate ligament knees, especially anterior cruciate deficient knees, or for revision surgery. And so, there's multiple studies that are looked at that show that, if you have a posterior tibial slope greater than 12 degrees, you're at risk factor of either failure of your revision ACL or failure of a primary ACL. And certainly when I have individuals that have failed a primary ACL, if they have a posterior tibial slope that's over 12 or 12.5, I will often look to do a closing wedge osteotomy to correct this. The pictures are a little bit grainy. Similar steps in the sense that with a closing wedge, you can often correct or count 1 degree for 1 millimeter of correction. This can be done with a tibial tubercle osteotomy where the tubercle is taken off, or in this case with the tibial tubercle left in situ. The most important thing is to ensure that you have a hinge, and often I will have to percutaneously poke holes in the back of the posterior cortex to allow for a little bit of movement. These can be fixated with staples or plates. I still often use staples with respect to this, and this is just an example of one that underwent a closing wedge osteotomy. I just want to point out that this is not new, even though orthopedics often thinks that they're at the forefront of innovation. This is something that's been done in veterinary literature for many, many years, if not decades. And so this is, in fact, my dog was a boxer bulldog who tore his ACL about 10 years ago. And so if you look at his x-rays, significant posterior tibial slope that he underwent something called a TPLO, which is a plateau leveling osteotomy. And he got about another good 10 years out of that knee before he unfortunately passed away. But again, just did a slope correcting osteotomy for his ACL deficient knee. So certainly, as I mentioned before, complex knees, when we look at ligament reconstructions, we always need to look at the alignment. But certainly, if I'm thinking of doing any sort of complex cartilage restoration procedure, whether or not that be autograft oats or allograft oats or meniscus transplants, the first thing you need to always look at is what is their alignment, and does that need to be addressed at the same time? If you can look no further than through the Mayo Group, and when they looked at their analysis of their failures from cartilage repair surgery, the number one cause for failure was felt to be malalignment. And so this is something that you need to address when you're doing cartilage restoration procedures. And so for me, I sort of break it down into coronal alignment, sagittal alignment, and patellofemoral, right? And so from a coronal alignment, indications for me are individuals that have single level osteoarthritis. They have chronic ligament instability. If I'm planning to do any sort of osteochondral transplantation or meniscus transplant, I will look at an osteotomy. I will look at closing wedge or opening wedge osteotomies for tibial slope and chronic ACL deficient knees, especially if they're revision scenarios. And then we didn't really touch on it, but obviously tibial tubercle osteotomies for patellofemoral. So the take home from hopefully from this talk is for me is that, patient selection is critical if you're planning to do an osteotomy in order to optimize the outcomes following osteotomy. Certainly with the advancements in techniques and fixation, osteotomies can provide reliable results of 10 years and I think likely longer. And then any individuals that have instability or complex knee pathologies, alignment should always be taken into consideration. And I'd like to thank you for your time, and I'd be happy to take any questions at this time.
Thank you, Robert, for this great presentation. Robert, you can stop sharing, actually.
Okay.
Thank you, Robert, for this great presentation and absolutely stunning cases and great correction as well.
Thank you.
Robert, few questions. Now, Robert, do you normally put a bone graft when you do these medial opening wedges? And what is the degree of correction? For example, the threshold of correction at which you start putting a bone graft?
If the correction's under 7 millimeters or 7 degrees, I often won't put any bone graft. I know there's abundance in literature that have looked at it, especially in Europe, with putting no bone graft, regardless of the degree of correction. If it's over 7 or 8 millimeters, I will often add Cancel's allograft. I don't add any strut allograft. It has shown to have an improved an increased time to union radiographically, but hasn't shown any difference between delayed union or non-unions, whether or not you use bone graft. But typically for me, I just like looking at x-rays that have bone that's healing quicker, if then not.
And also, what is the upper limit of correction? What is the amount of varus that you can correct with an HTO? Suppose it's say 17 degrees of varus. Would you still go ahead with an osteotomy, or would you consider some other procedure?
Yeah, that's a great question. I didn't talk a ton on it, but if it's under 12.5 millimeters, I will often go to an osteotomy, an HTO, a medial opening wedge. If it's anywhere from 12.5 to 15, I will instead of doing an ascending biplanar cut, I will do a descending biplanar cut. The advantage is that it hopefully avoids any development of patella baja. The disadvantage is it's another osteotomy site where I will put screws and almost like a associated TTO. If the correction's over 15 millimeters, then or 15 degrees, I will start looking at double level osteotomies. Because my concern is if you have a 17 millimeter correction, you're going to create joint line obliquity. And so from then I will often template addressing both the femur and the tibia to try to avoid any joint line obliquity.
And you always look at the PTA and the LDF here, right?
Correct. Yeah.
And have you encountered a situation where you have a varus knee and the problem was only on the LDFA? The MPT was normal, and did you do a femoral osteotomy alone?
I have not for varus knees, but I'm waiting for that day.
So you expect it's going to come one day, right?
Yeah, it's
coming.
Okay, great. Thank you. And we also joined by Loy. Loy Al-Khatib is an orthopedic surgeon specializing in knee and shoulder from Dubai. Loy, welcome to the show. Any questions to Dr. Robert?
Good morning. Good morning to Longstaffe. Can you hear me, guys?
I can hear you.
Yeah, sure.
Thanks. Robert, I think I still remember that the day that we discussed how to correct the posterior slope using the HTO, the same time he was doing HTO and controlling the slope. Do you still think there's still an idea how we can manage that, hit the two measurements in one operation, one go? That means that you correct the varus and the posterior slope in one go. And this is the first one of the first questions they asked me. The second question is, this is regarding complex cases, the patient they do have, they need osteochondral transplantation, ACL, and HTO. What would be your order in terms of correction?
Yeah, great questions. I think when you're looking at trying to address the slope from a medial side, I think the only thing you can do is avoid iatrogenially increasing it. I think if you're looking to try to address the slope and the coronal deformity, you have to start looking on the lateral side, but that's a very hard, very tricky surgery. And so from my standpoint, whenever I'm doing a medial opening wedge osteotomy, if I'm looking to try to correct the slope, I don't think you can lower the slope on a medial side if you're doing a medial opening wedge. When we're looking at cases that have, I believe you said an ACL transplant and varus,
and HTO, exactly.
Those are very tough cases. I'll be honest, certainly in a Canadian setting, often what I will do is do I assume this is a chronic deficient knee. I will do the HTO first, especially with the cases that are potentially proceeding with a cartilage restoration. I will do the HTO first to see whether or not they're symptomatic afterwards. And if they're not symptomatic, then sometimes I don't even have to do the cartilage restoration procedure, where if they're symptomatic, then I will address that at the same time. I've done HTOs with ACLs. I think that is not a significant, it's sort of two separate surgeries that are together in the sense that I'll often do the HTO first in the same setting. Often you'll find the anterior two proximal screws can get in your way of your tibial tunnel. And so what I will do is I'll do the entire HTO. Then I will plan my tibial tunnel for my ACL. And often you'll have to remove one or two screws. And then I will actually measure while looking through the tunnel so that I can get the screw trajectory right up to the tunnel where it's not approaching it. So I will take those two screws out and then I'll put two screws back in that are lesser, but obviously not impinging. When we're talking about adding meniscus transplants and allograft oats, I'll typically do the osteotomy first. I'll see how they're doing. And then if they're still symptomatic, then I'll plan to go ahead knowing that I've already corrected their alignment. Because you'll be surprised, often you don't have to go to that next step because the osteotomy's unloaded them.
That's true. So one thing that I have learned from you is use the offloader brace for at least 3 months and see how they respond to the offloader brace. And this is give you a hint. This is a good trick.
Yeah, you'll get, because I do joint replacements too. And so when you see individuals, sometimes it's hard, they're in the gray zone. To me, it's not an age issue. It's an activity level, right? And so I usually explain the pros and cons to both. Some individuals still, they don't entirely understand what an osteotomy is. And so I will use the unloader brace as an external device, more as a prognostic device to see, do they like the feeling of having something where their knee is straight, or do they hate it? And so to me, that gives me a little bit more information as to whether or not I lean towards an osteotomy versus a total knee.
Exactly. I remember my first osteotomy here in Dubai. When I did it, I asked him not to do any bear weight bear for at least 6 weeks because I was afraid from the then union, and he was a heavy smoker. Thanks God I saw him last week. He's doing well. The axis is completely normal now, the mechanical axis back to normal, but still have some issues with his cartilage. I might go and do some transplantation.
That's exactly how I would do it. I'd unload them first, and then if you have to, go back if they're still sore.
Awesome. Thanks, Rob. Thanks for, I think that's it, Hitesh. This is the question that we had.
Thank you, Robert, for this great presentation. I think that's all the questions that we have for the session. And we really look forward for another one in the future. Thank you so much for joining.
Well, thanks so much for inviting me.
Thank you. Bye-bye.
Take care, guys.
Thanks, Rob.